Hello, everyone, and welcome to our panel, Election 2025, Steps to Heal Canada's Healthcare System. I'm Kelly Grant, a health reporter here with the Globe and Mail, and I'm so pleased to be your host and moderator today. Before we begin, I would like to acknowledge that the Globe and Mail's headquarters is situated on the traditional territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. My colleagues and I are grateful for the opportunity to live and work on this land. Now, over the next hour, we're going to talk about a subject you will not hear discussed at the federal leaders' debates this week. As some of you in the audience may know, CBC Radio Canada, which is hosting the official debates on behalf of the Leaders' Debates Commission, announced yesterday the 5 themes for the French and English debates. Healthcare did not make the list for either event. Now, we all know that the elephant to our south is overshadowing everything during this election campaign, but we also know that every day, healthcare, or the lack of access to it, touches the lives of all Canadians, and it moves their votes. So we've decided to host a healthcare discussion of our own with some of the top experts in the country. I'm so pleased to be joined today by Andre Picard, the Globe and Mail's esteemed and long-serving health columnist. Also joining us is Kevin Smith, President and CEO of University Health Network, Canada's largest academic hospital network. Tara Kieran, she's a family physician and researcher at Unity Health Toronto, the Fidani Chair of Improvement and Innovation at the University of Toronto, and host of the new podcast, Primary Focus, so make sure you check that out. And also, finally, we are joined by Joss Reimer. She's the president of the Canadian Medical Association and a public health physician by training. Dr. Reimer is a former Chief Medical Officer of Health for the Winnipeg Regional Health Authority, and she was the medical lead for Manitoba's COVID-19 Vaccination Implementation Task Force. So thank you to all of you for joining us here today. Now, before we get started, I have a couple of quick housekeeping notes for the audience. First, as we go along, please feel free to add any comments or questions for today's speakers using the live Q&A button on the upper right of your screen. We will have some time for audience questions later, and I'll be pulling from some on that list. Now, if you have any audio issues or other technical problems, please see the support chat button in the lower left of your screen. We will also be sending a link to this webcast recording to everyone who registered, so please feel free to share it. And an edited transcript of our conversation today will be featured in an upcoming edition of the Globe and Mail. All right, so welcome to everybody. I'm so happy to have you all here. All right, I wanted to start off with a question that, even though healthcare has not figured prominently so far in the election campaign, one thing that all the parties have made a promise of one kind or another about is access to family doctors and primary care. That is Dr. Kieran's area of specialty as a researcher and a practitioner. And so I wanted to ask you, what do you want to see the next government do to help guarantee every Canadian access to primary care?
Yeah, such an important topic because, as we know, and what we found from our survey that we did back in 2022 was that more than 6.5 million people in Canada don't have access to a family doctor. But I think what was striking to me about our findings was, although that stat is like more than 1 in 5 across the country, we saw that there was immense variation actually in access across the country. So in places like Quebec or the Atlantic region, it was actually almost 1 in 3 people who didn't have access to primary care, which is really that front door to the health system. And so I'm glad that parties are recognizing that this is an issue. But what I would like to see, is all of the parties kind of committing to 3 things. 1, more money. 2, more accountability for access, and 3, a real coordinated national strategy that ensures a minimum standard for access and kind of the relationships that underpin it. And so just to dive into that a little bit, why more money? When we look to our peer countries across the globe, we know that they actually on average spend a greater proportion of their total health budget on primary care than we do in Canada. So it's clear that we need to kind of shift our spending. We probably have to grow the whole total health pie, and we can talk about that in terms of health spending, but we also need to, within that pie, ensure that we put enough dollars out there for primary care and what we call often those upstream issues. So trying to prevent people from having problems, to prevent them from having to get into to a hospital, for example. So we need to spend more money on primary care, and then we do need more accountability. And I think there's a couple of different ways we can do that. So one is, I love Dr. Jane Philpott wrote a book, Health for All, and in it she proposes a Primary Care Act, and I love that proposal because it builds on the Canada Health Act, but it goes further to say that actually primary care should be something that's guaranteed to everybody, no matter where they live in Canada, just in the way like a public school education is for kids. And so, I'd love to see parties putting forward a commitment to pass that kind of act. And if they feel like that's, too much, they don't want to propose an act, they can always put forward, okay, we're going to do it through the usual way, health transfers, but with much more teeth and accountability. Because right now we know that actually in the last set of negotiations between provinces and the federal government, they actually went forward with more health transfers for family health care in theory, but there was such little accountability for it and such low targets. It was not ambitious in the way that it needed to be. And then lastly, I would say we absolutely need that strategy, because if we don't have a strategy across Canada, we're not going to be able to raise that standard to the place we want to. So that includes health human resources. How are we going to make sure we have the doctors and nurses, etc. But it also includes learning from one another, because each province is doing things to try and address the crisis right now, but actually we're not learning from each other. And we need kind of a minimum set of things that we're going to move forward so that every person in Canada can feel comfortable that they're going to have this access no matter where it is that they live in the country.
Hey, thanks a lot, Dr. Karen. You mentioned in there about kind of what are the consequences if people don't have access to a family doctor. And one of the consequences over the last few years has been this real rise in virtual care as an option for people. And in a lot of cases, we're looking at for-profit virtual care companies who are charging things like membership fees or subscription fees for medically necessary services. This, again, is something that the federal government does have a role in because they set the terms of the Canada Health Act. The last health minister put out an interpretation letter that left this question of, pay to play primary care kind of in a gray area. Dr. Reimer, I know this is something the CMA has been thinking about. So what do you think? I mean, if we can't provide people with enough doctors through the public system, should people be allowed to pay out of pocket, especially for something as convenient as virtual care?
Yeah, I think that's a really important question because access to care, like Dr. Kieran said, is such a fundamental issue for Canadians. And last year, together in partnership with the Globe and Mail, we hosted a series of conversations across the country. And between those conversations and surveys, we talked to 10,000 Canadians. And they told us that their number one concern was access to care, but that access to care should not be determined by whether or not someone has the ability to pay. So that was the message we got loud and clear when we talked to Canadians. We also did a literature review and a jurisdictional scan and really found that when we look overall, broadly speaking, lots of caveats, at private and public care, the private care tended to be more expensive and have worse outcomes. So that's not to say we shouldn't have private services in our health system. In fact, about 30% of our health system is privately funded right now. But it does mean that we need to be really cautious when we're looking at private solutions because they can be more expensive and sometimes have worse outcomes. And that's not where we want our solutions to be. We want to find the most cost efficient and the best outcomes we possibly can. And so the interpretation letter was really helpful because it did tell us that things like nurse practitioners doing primary care should be considered part of that public purse. We should have an expectation as Canadians that under the Canada Health Act, when we're getting primary care from a physician, from a nurse practitioner, that should be something that's covered by our provincial health insurance. But as you mentioned, they didn't talk about virtual care. And we'd love to see virtual care also being considered part of that public purse, that whether you're seeing your doctor in person or you're seeing them virtually, that you should have the expectation that that is something that is provided for you by your tax dollars. And that's something that we've heard from Canadians that is really important to them as well. The final thing that I'll say is that one of the biggest struggles we have in the Canadian health system right now is that we have a crisis in shortage of health human resources. So Health Canada recently released a report saying we're 23,000 family physicians short across the country. Those are the same physicians who would work in a private or a public setting. So when we look to these private solutions, so companies who are going to offer pay for virtual services, we don't have additional physicians who are coming in to provide those services. Instead, it's the same physicians who would be in the public system, but will end up getting pulled out into the private system. So I think we could have a very different conversation if we had additional physicians, if we had a surplus of health human resources. But in this deep shortage that we're experiencing, we know that when we invest in these private solutions, we do it to the detriment of the public system. And that means the people who can't pay will experience worsening access to care if there's even fewer physicians available to them. So these are the conversations that we really need to have before we try to come up with these quick solutions where we can plug in a private pay option because it looks like it's filling a hole, when in fact, we're just moving the hole from one part of the system to another.
Dr. Smith, it looks like that's something you want to respond to. Why don't you jump in?
Thank you so much, and thanks for convening us today. I think maybe an example of where digital or a virtual care worked really well. During COVID at University Health Network, we went from about 200 virtual visits a month to over 11,000 virtual visits a month. And it was actually good for everyone. It was, of course, in the public pay system. And afterwards, as we came out of that and we changed the fee schedule, we no longer rewarded virtual care in the same way. So I think in our discussion today, important to recognize that we have the system we incent. And if we follow the incentives, we sometimes better understand the behaviors. We're fortunate to be doing some work with the province of Nova Scotia in virtual care, where urgent and primary care is available using technology with a UHN physician. And what's been fascinating is 90% of the people who are coming to be seen don't require a visit to hospital or clinic. The physician or nurse practitioner can order lab tests, drugs, etc., and coordinate back with those who do have a primary care provider the results of it. Interestingly to me, the other piece is to Dr. Reimer's last comment, you're only eligible to provide service in that model after you take a full complement of emergency room shifts in your host hospital. So we aren't bleeding away from emergency rooms and making it more advantageous to do virtual care. We're looking at it as a privilege to offer after your emergency room services are delivered on site. And if you have more capacity and you're interested in providing that model and it's appropriately remunerated, tremendous attraction and among our highest patient satisfaction.
So much depends, I think, on, as you say, how the system is designed and what it incents. And there's probably a really exciting role for virtual care in lots of parts of the system. But I did want to follow up and ask you, Dr. Smith, that some of these new innovations, be it in drugs or technology or the way the system is governed, some of these things do wind up adding costs, and we do see the overall costs continue to rise. We see the federal parties making a lot of promises to spend a lot of money in a lot of other areas. Do you think we have the ability as a country to have the public purse keep pace with the increase in health spending?
Yeah, it's a great question and a challenging question. I know when people poll and say, do you want to pay more taxes? Not a lot of hands go up. But when you say, do you want more access to high quality healthcare? A lot of hands go up. Mm-hmm. And for our political colleagues, that's challenging. I think what we are recognizing is perhaps could we use those resources more effectively, obviously? And should we be looking at other forms of revenue that already exist in the system? Well, perhaps one example that we're toying with as a large employer, as well as a healthcare organization, could our benefit plans be unlocked in some way to support the people who work at University Health Network and their families with better access to primary care? Are there other expenditures within the public and private purse that wouldn't disadvantage, particularly the most marginalized citizens amongst us, but bring new revenue to the system? And every year, we start the year on April the 1st underwater as a large academic hospital system. So we would roughly see, and this is true across the country, 2 to 3% funding, and we would be increasing our spend by 6 to 7% funding. Particularly for places like where Dr. Kieran and I work, we're also looking at the latest technologies. So if you're coming to Princess Margaret Hospital, you expect, and you should expect, the latest and greatest cancer care. That doesn't get achieved by a peanut butter spread approach to healthcare funding. If we want the best care, then we can't simply allocate funding in a equivalent way across all organizations. It probably does call us to ask, how many centers do we need for some of our higher end, more expensive interventions? And we know that volume can also be related to quality and cost, so that'll be an important consideration. But ultimately, when you compare our spend per thousand population, we are underfunding healthcare, and I would say add to that research quite dramatically when we compare ourselves to the G7 countries. And as Dr. Kieran mentioned, the geographic maldistribution is a challenge. I truly think, Kelly, that digital care does offer us a remarkable opportunity to make equitable access, particularly to specialty care, significantly advanced.
Thanks a lot. I heard something in there that I want to pick up on, and that is your contention that we are significantly underfunding healthcare. Andre, do you think we're underfunding healthcare in Canada?
I'm not sure. I'm not sure we're underfunding. I'm not sure we know what we're funding or why. So I think that's a fundamental issue. I think what is clear is we don't get value for money for what we spend. We have, I think, the least universal healthcare system in the world. You know, we fully fund hospitals and doctors, but everything else is really all over the map. Other countries, Nordic countries, European countries, where I think we should be looking for ideas, fund much more broadly and much more deeply. And I think we have to rethink pretty fundamentally as the world changes, how we change our system. Our system was built in the 1950s and 60s. It was built for a population at that time, and it's just not, the funding system is not modern. We could certainly spend more money, but I think first and foremost, we have to spend it better and smarter.
A way in which we could definitely modernize the system would have to do with how we handle people's medical records. You know, that's one place where I see things as being fairly far behind. Our colleague Chris Henne in the ROB just wrote a big piece about the frustration people have getting to see their own records. I wonder, Andre, if you see that is something that Canada as a country could improve on and that the federal government could do better on, and why it is that it has been such a hard problem for us to solve.
I think it is a really important issue. It's one of the biggest frustrations of patients is just having to repeat and write down your medical history on a clipboard time and time again. You know, I think our medical system is the largest contributor to the clipboard industry in the world. That's a lot of useless paper. We have to remember the Canadian health system, the principal means of communication is still the fax machine, which is 19th century technology. We really have to get into the modern age. Now, the last government had legislation, Bill 72, to bring in, to sort of clean up the mess in data to ensure that systems are interoperable so they speak to each other. That's our biggest problem. We have a lot of systems, way too many of them. There's maybe 30 electronic medical records in Ontario alone, and most of them don't even talk to each other. We can go on where Dr. Smith works on Pill Hill on University Avenue, and some of those hospitals can't speak to each other. It's easier to walk across the street with a piece of paper because the systems are so out of whack. So there's really some serious work to be done there. And part of that is ownership from patients. Patients' records should belong to them. They should have access to them. And that should be a cooperative venture between medical professionals and patients. And we just don't have that access. We have a lot of frustration and a lot of outdated technology there.
Maybe I'll just jump in there, Kelly, just to say that we've had these dialogues with patients and the public across the country, and we talked to them about primary care and what they wanted to see in a better system. But actually, again and again, they brought up this issue related to medical records and how frustrating it was for them not to be able to have access. And so it was a very clear recommendation from them. And what I've seen from looking across other countries is that, you know, there are many other countries that now have legislated the right for patients to be able to have their own record. And you know what I also understand from my conversations with a number of experts is that until we legislate that, many of the the private companies as well as even public institutions don't have an incentive to invest in the solutions to enable that interoperability so that everybody can have that record right at their fingertips. There are countries like Spain since 2009, everybody has on their app everything that they need, in their fingertips. We're a relatively rich country. There's no excuse for why that's not the case here. And I will just add, to our other point about sustainability, when we've been doing this dive across, looking at other countries and learning from them, it's also been really striking to me to see that, many of the other countries, they spend a much higher proportion of their total health budget in the public system. That's in fact one of the most striking differences between Canada and many of the countries where we look to because they have, better primary care, for example. So countries like the UK or the Netherlands, Finland, New Zealand, Germany, France, they all spend more in the public system than we do. So just to reinforce Andre's point is that, we spend a lot of money, yes, but are we spending it in the right way? Are we spending it in the public system? And are we spending it on the right types of services? We also heard from people across Canada that it wasn't just doctors and hospitals that they wanted access to. They wanted access to mental health care and dental care and pharmacare. So, there's a whole slew of things we need to be thinking about.
So as we've been talking here, I've been getting a couple of questions in from the audience. So I wanted to throw one in, and I'm going to direct this one to you, Dr. Reimer. And that is, we've got a viewer who's asked, what is being done to streamline the provincial regulatory approval of doctors? And how could the federal government play a role there?
Yeah, I think that's a great question because streamline really is the word we want to use right now, because health is a provincial jurisdiction overall. There's lots of roles for the federal government, but broadly speaking, it's provincial. We regulate our physicians at the provincial level as well. And that means that each province has a bit of a different process. And so that can be very frustrating as an international medical graduate trying to find your way through the system. So for a lot of countries, it's pretty quick. We recognize that, folks from England or Australia have similar training to us, and you can get into our system fairly quickly. But when you're from another country where the system's quite different, it becomes a labor-intensive process where we do a lot of individual assessments of somebody's skills. And that may be necessary to do that assessment because we want to make sure that if we have a family doctor coming into the system, that they're going to be safe and providing the level of care that Canadians deserve and should trust. So we don't want to just streamline it to the point that we're putting someone in who's never treated children, for example. But we also don't want any more of these stories where there's these qualified medical professionals working outside of healthcare, not able to use those skills. And so one piece of hope that I would say I've seen is a clinic that newly opened in Halifax, where they are now doing something they call practice ready assessments, meaning they do several months of supervised practice. So the whole clinic, it's like a teaching clinic, but they have internationally trained physicians working there being supervised by Canadian physicians for 3 months or so. And the idea being at the end, they will either get a check mark, yes, you're ready to go, practice in Canada, here's your license, or you might need extra training in parts A, B, and C, or we can get you this tailored license where you can go and do a procedure clinic, but maybe you won't do full scope family medicine, for example. I've never seen a clinic like this anywhere else in the country. There may be some I'm not aware of, but it gave me some hope that we now have an example of a process where instead of these one-off assessments, there's actually a way that international grads can go into the system, get assessed in a comprehensive way that's going to be trustworthy, and get them into practice sooner. We're just going to need some resources. And this is actually something I'd love to hear from federal candidates about what they plan to do for the health system. If they wanted to, they could fund these types of clinics across the country so that we have opportunities across the country to do a good assessment of the internationally trained physicians and get them into the system faster.
I really love that example. I want to turn to you, Dr. Smith, now to ask you also about this question of trying to bring in doctors from overseas, because UHN announced last week, I think it was, that it's got, a flashy campaign to try to attract 100 early career scientists. And really, you're targeting the United States and so many of the researchers there who are concerned about what the current political climate means for their grants and for their future as scientists and doctors. So what do you want to see the federal government do to make sure that there's a smooth path for those people who are looking to move to Canada?
Yeah, I think exactly what you've mentioned. One, less red tape. So how do they get here? In our focus, it is early career scientists, some of whom will be clinician scientists, not all. Some will be PhD basic scientists. But for us, the excitement, I think, was in hearing all the party leaders talk about a transformation of our Canadian economy into a knowledge-based, science-based economy. And if we truly mean that, then we need to think about how do we not only create science, but exploit science and build a manufacturing environment and job creation. I think all of us felt during COVID, like, why are we dependent on a foreign nation to allow supplies like vaccines to flow to our country? Why are we not producing those right here in Canada? And the example we've used, as you and I have discussed, Kelly, is the insulin invented here in Toronto, first used at Toronto General, now manufactured almost exclusively in the United States, Denmark, and France. For us, I think it is a bold opportunity with the federal government to dramatically increase access to science funding, to actually create a career path for individuals. Not only young scientists, the ones who are struggling most are often mid-career scientists. And then how do we marry those up with industrial opportunity? So maybe I'll just give you an example. If you were a vaccine scientist or virologist right now in the United States, or particularly in the United States, you might not be overly successful in attracting funding. If you're a vaccine manufacturer, the current environment doesn't suggest a great deal of support for vaccination. Why wouldn't Canada, where we have fantastic vaccine science, fantastic basic science, fantastic clinical opportunities, and literally the world's genetic gene pool? We are the most diverse country and city on our planet. So for clinical trials, it is the ideal place to do that work. And why wouldn't we marry that with attracting either a Canadian or a multinational company who would actually build and leverage off the affordable, high-quality science that's being produced by Canada? Build a tax system that allows people to be more attracted to investing in science. And then, of course, build a reward system that sees in taxation with manufacturing a protection of our universal care system. Without that, I think many of us are feeling that this is at risk as our economy is increasingly at risk. So I think this is something I hope whoever the next Prime Minister of Canada will boldly embrace. And everyone's talking about transformational. I'm going to be a little bit critical. Canada's not well known for transformational. We do incremental really well. If we're going to be true, I hope we hold the next Prime Minister of Canada accountable to that, build a transformational science-based economy and start with research and science.
All right, Dr. Reimer, looks like you've got something you want to add to that.
Yeah, absolutely, because I would love to see all the investments that we just heard about, but there's also some cost neutral things that the government could do quickly. And we have a window of opportunity with US physicians wanting to come to Canada because some of them will still leave the US but may go to other places. And we need to see the government fast tracking visa applications because that is something that is squarely within the federal government's control. And so they could help US physicians get their visa to come to Canada quickly. They could eliminate the need for things like labor market assessments, because right now we have to prove that we're not able to fill these vacancies with Canadian physicians. Well, when it was the government's own report that said we're 23,000 family physicians short, I think we have a labor market assessment. And we also, I recently heard from a US physician who's already here in Canada, talking about how hard it is because there's no path to permanent residency. So he's here, he's working, his family is here, but he's on this work visa and doesn't have a way to progress to stay. And these are the folks we want to really make sure that they stay and become part of the community. And the federal government could help reduce some of those barriers in a cost-neutral way to just make the immigration process easier for the physicians who would help make our system stronger.
Kelly, I'll just add 35% of the people who've signed up to express interest from the United States and around the world to come to our Canada Leads 100, they're Canadians. They want to come home.
That's really interesting. That sort of, to me, speaks to, I mean, that's bringing physicians and scientists back, but it also speaks to me to the idea of retention. And so there's sort of two ways to ensure that we have enough trained professionals to provide Canadians the access that they deserve in their health system. One is, of course, recruiting new people, but the other is training and then retaining the people we already have. So I wonder maybe if I could start with you, Dr. Kieran, what you think needs to be done to keep the health workers we do have continuing to want to work in the system.
Yeah, great question. And so, I think when we think about the training and retaining portion of it, maybe I'll start with the training part, because I think that's something that we've done actually a pretty terrible job with over the last 3 decades. When we compare ourselves to other countries, we have a lot less doctors per capita. So, if many of the European countries might have like 1.5 times or more doctors per capita. And this all goes back to decisions from the 1990s about restricting medical school enrollments as a cost-saving measure. And we've seen where we're coming, because we've had a lot of flaws, I think, in our planning process. Not only do we have an aging population where we need kind of more doctors to be able to serve people because they're living longer and have more complex conditions, but we also have a workforce that wants to work differently. So, they no longer do people want to work the hours that previous generations worked. People want more flexibility in their work life, and they want to actually concentrate on the doctoring part, if they're doctors, or the provision of the actual care if they're another health professional group, as opposed to some of the bureaucracy and administrative pieces. So we haven't accounted for the changing workforce and the preferences of the workforce in terms of how many hours they want to work. And so we need to ensure that our federal government is planning for the future, taking population growth and workforce patterns into account, and funding the right number of medical school spots and the right number of residency spots across the country. Yes, we can absolutely fill some of the hole from bringing in people from other countries, but that's only going to get us so far. And the U.S. is one specific example, but we don't want to poach or take doctors from countries where there's a huge need for them, and they've paid through their hard work and taxes to train those doctors. So we need to be careful about that recruitment strategy. I agree with much of what Dr. Smith and Dr. Reimer had said. And we, at the same time, build our training capacity. What that's going to also mean is that the federal government and others will have to fund current doctors to actually teach. Pretty much, if we want to train, the 23,000 family doctors that we have short, every family doctor in the country is going to need to be a teacher. The other things that we need to do is make this the work life even better than it is right now, because that is, as you mentioned, one of the reasons why people are leaving. And so some of this relates to things we've talked about, IT connectivity. We have terrible information systems that hurts patients directly, but it also is terrible for doctors. I can't find, for example, that it's hard for me to know what specialists are practicing in a very specific area, in my city, and what their wait times are. None of that is actually available at a click of the button in the way that it should be. And I shouldn't have to navigate that myself as a doctor. I should be able to just say, this person, they need to have a certain type of surgery. Let me just put in that referral. And there should be a central place that actually figures out what the right type of surgeon and where it is that they can get that. So we need better information systems, better processes and infrastructure. We need the actual buildings and the IT provision. Doctors don't want to do that kind of stuff anymore. I also want to think about and so we need governments to actually help set that up. And the work environment in many hospitals now for our nursing staff and others is terrible, because they're often actually understaffed, and we've got often patients who are in a lot of distress, and unfortunately often they are the recipients. So we need to really figure out how to make our spaces safe for all of the people who are working there. And then I think the last thing I'd say is, we're not going to be able to do it alone. Because we have these health human resource shortages, we absolutely have to figure out how doctors work together with other professionals, and how we support patients to also become better, more empowered members of the team, so that as patients, they can actually navigate their journey more easily. And then so the doctors and the other professionals can just support them in a way that enables them to live their fullest life.
Dr. Reimer, I saw you nodding pretty enthusiastically there when Dr. Kieran was talking about other professionals. I love asking this to doctors. Do you think we should be channeling a heck of a lot more of this work to other providers like NPs or like pharmacists?
I think we work best in teams. And I want to see some big, we talked about transformation. I would love to see some transformation where the assumption becomes that we function in teams and that we fund it so that we can function in teams. I have worked in a clinic where I had nurses, a pharmacist, a dietitian, physiotherapist, social worker, all in the clinic with me. And I can tell you that for me as the physician, it was so much less stressful for me. And it was so much better for my patients as well. I do mostly prenatal care. And so I'd have someone with pregnancy-related diabetes come in and they'd see me, I'd check their sugars, check their blood pressure, adjust their medications, but then they'd go see the dietitian and spend 30 minutes learning about low-cost, diabetes-friendly diets. They'd go see our pharmacist who would teach them how to use their glucometer to check their blood sugar at home. It was so much more efficient for me to be able to share with the other team members, and so much better to have their expertise because we know the dietitian has more nutritional training than I do as a physician. And then the patients would sometimes come in and just see the physiotherapist because they didn't need to see me that day. That's the type of team we really want to build so that patients get access to the right provider at the right time. But I think the key part is that it's a team. We don't want isolated practitioners working where we're not sharing information. We really want to be in the same space, sharing a health record so that we know that, oh, this is actually their 5th bladder infection this year. Let's not just prescribe them antibiotics again. Let's make sure that we're looking in to see why this keeps happening. And building on the expertise of the different team members together makes us stronger as a whole and can hopefully make the system more efficient and allow us to bring on more patients into each primary team's panel when we can share like that.
Dr. Smith, you've got something you want to add there?
Yeah, 2 things, if I might. One, completely agree with my colleagues. I think scope of practice is something we've talked about for a long time, but we really haven't maximized in terms of all of the professions. And if we look around the world, not only in the regulated professions, but in extenders, some of the best places in the world, the best institutions, both in primary and secondary level care, are looking at how they create new professions and augmented professions and truly let people move to their full scope of practice. The second comment, if I could, is when we look at medical education specifically, based very much on the Flexner Review of 1910, right? So if we really think about how often have we reformed medical education, is it still necessary in times like these that it takes 7 to 9 to 12 years to train a physician, depending upon discipline? Or could we actually say, we're going to put a challenge out to think about how do you trim a year or 2 off each of those opportunities? And with technology, with clinical opportunity, with greater scope of practice, I think our academic establishments have the opportunity, if challenged, to actually reinvent medical education as it was done some number of years ago when problem-based medical education really converted us from a didactic learning to a patient-based model. We need that re-innovation in our academic space as well as our clinical space.
I want to go to a couple of the questions that I'm getting here from the audience, and one I'd like to put to you, Andre, and that is on our current discussion here about health human resources and how we get more people working and staying in this healthcare world. I've got a question. Is there a plan for attracting health professionals in rural and remote areas?
I'm not sure there's a plan, but I think we know from the research how to do it. We know that if you want people to practice in rural areas, you have to train them there. So we have to decentralize our medical education. It comes back to part of what Dr. Smith said. Education has to change quite fundamentally. We're in an era where things change so quickly that there's stuff that people learn that is not valid by the time they graduate. So I think, to me, the future of medical education is teaching people how to learn continually and to adapt and to be resilient rather than teaching them stuff. For a century, we've been filling doctors' heads with stuff. And I think we have to teach them to learn better and faster, to work in teams. I think it's about how we practice more than the stuff. So no, there's not a plan. There's certainly a need. We know that all the problems we've talked about today are 10 times worse in rural and remote areas. It's far, far worse. So we have, we talk about 2-tier healthcare in Canada. The real 2-tier is urban and rural. It's very, very different. And the care is disgraceful at times. I think there's no other way to put it.
Mm-hmm. Dr. Curran, you wanted to add to that?
Yeah, just to build on what Andre was saying, that when we think about remote communities in particular, so many of them actually are Indigenous communities, and our health outcomes for people who are Indigenous in Canada are much poorer than health outcomes for people who are not Indigenous. And this is an area that the federal government has direct control of. And so, we need our federal government to show more leadership and ambition and commitment in reducing those gaps in mortality between people who are Indigenous and people who aren't, ensuring better healthcare on reserves. And so when we think about rural and remote, I think we also have to think, and urban, to be honest, too, because many Indigenous people are living in urban centers. I think because this is a federal election, I think we need to specifically think about what is the federal government going to do for people who are Indigenous. And that includes also workforce training, because we know, people who are Indigenous make up about 5% of the Canadian population, but less than 1% of doctors, or about 1% of doctors, are actually Indigenous. So we need health human resource strategies too, to grow the workforce to be more representative of the actual populations we serve, particularly people who are Indigenous.
All right, we've got about 20 minutes left here. So there are a couple more topics I want to make sure we hit. And one of those is pharmacare. So as everybody knows, the last Liberal government passed some legislation regarding pharmacare. They've done some deals with provinces that would see federal money being spent on providing coverage for some birth control options and diabetes drugs. What would you all like to see the next government propose and pass as far as pharmacare is concerned? I'm getting a big smile from Dr. Kieran, so I think I will go to her first and then see who else wants to weigh in.
Yeah, I mean, we absolutely need a national pharmacare program. What we have proposed right now and moving forward with is a start, but it is a very, very small, modest start. It is really frustrating and feels awful, really, to be in a clinic room with someone and know that there are treatments available for them, whether that be for their depression or their high blood pressure, for their diabetes, but that those treatments are going to be a challenge for them to be able to afford to get. It's awful because there's nothing I can do to help people with that challenge right now, or very limited means of what I can do to help them. And so, many countries, most I would say, that pride themselves on the kind of ethos Canadians do, that care should be based on need and not ability to pay, they include pharmacare in their universal health insurance package. There's been lots of evidence that actually even also shows that if we spend more as a country in pharmacare, publicly covered drugs, we can negotiate better and actually bring down costs, which is an important part of it too. So it's the right thing to do from a public perspective in terms of getting people the care they need, but it's also the right thing to do from an economics perspective. And so I'd love to see us move further and have the long view in mind, not just the short kind of cost view of how much it might be on the ledger over the next year, but really, what is that going to save us in terms of dollars by better negotiation of drug prices, and also what that's going to save us in terms of better health of our population.
Thanks. Dr. Smith, you wanted to add something here?
Yeah, I couldn't agree more philosophically, but here's my challenge. We continue to see federal governments inadequately fund the broader public purse. So whether it's physician compensation or other initiatives, number of beds per thousand population, my worry is we'll drift into another political announcement with a partial funding that at the end of the year will leave us scrambling for actual coverage. And to me, one of the most important things for us to do is to step back and actually better understand the transfers. If you can actually figure out a transfer payment from the federal government to the provincial, any province, I think you've got a PhD in something I've never heard of yet. It is so complex to drill down that to the theme of accountability and transparency. We really do need to better understand what's the federal role, what's the provincial role, and how do we see those resources actually being translated into action? And then with the public, with the consumer and the provider community, talking about what's the next fundamental step in investment. I of course, completely agree with Dr. Kieran's comments about the access to drugs, but I also know it's a bit like squeezing the balloon. Whatever happens to be the latest political hot potato gets addressed. Sometimes these are actually the symptoms, not the illness of our healthcare system. We need to really look at what resources exist, where do they come from, who are they flowing to, what are the deliverables, and are there some actual KPIs? Are we performing well? And if we're going to add more, to whom? So as an example, many of us are very fortunate to enjoy a wonderful drug program through our employer. So that isn't something that we need to defray by public expenditure. But for those who do not, absolutely, especially those who are most disadvantaged, we for sure need to consider that. But I would say the next government, if serious about really looking at protecting our healthcare system, has to stop and evaluate the funding sources, the lines, the flow, and the transparency of what happens when it gets to the provinces, how they use it, and then frankly, a scorecard for all of us, right? For including the patient, how we use the system, how the system's funded, what results we're getting, and if Tara and her colleagues are doing better than me and my colleagues, I should go and learn from her and up my game. And at the moment, we don't have that closed loop. It's overly political and not nearly measurable enough for us to reward true excellence.
All right, Dr. Reimer, I see you've got your hand raised and are interested in jumping in. Go ahead.
Yeah, absolutely. So I would completely agree with what Kevin was saying about the need for accountability. That it is very challenging, if not impossible, to know how federal dollars end up getting spent by the provinces, and Canadians deserve to know how their tax dollars are being spent and whether or not it's working. We've called at the CMA for a chief health accountability officer because it is so complex. You really need someone with the time, the expertise, and the resources to track this. But I also want to highlight some of the things that Dr. Kieran said about how cost saving something like pharmacare really can be. From my own experience, like I said, I work in women's health. I've had countless women who have not been able to afford their contraception. And so I've had two choices in front of them. One is to get a tubal ligation, so an invasive surgery that truly costs the system thousands of dollars to have surgery because they need anesthesia and OR time and all the equipment, or they risk having an unintended pregnancy, which costs them personally as well as the system a lot more money in managing this unintended pregnancy and then the child that comes from that. So these are two expensive outcomes compared to, for an IUD, you could spend $100 and get a copper IUD, and that would be very effective for most people. The same goes for diabetes, where if you have access to diabetes medications, you're going to avoid the potential amputation in the end that's extremely expensive for the system to cover. I was recently in Germany talking to my German counterparts and trying to explain to them that, yeah, drugs are free if you're in the hospital, but as soon as you're discharged, you have to pay for them. And they were just baffled by that concept because we are so ingrained in the current system that that's just normal to us. But to them, the idea that we would publicly pay for in-hospital medications, but as soon as you're discharged, you'd have to pay, made no sense to them because they pay for that. In fact, most European countries will include pharmaceuticals in their public offering. And so this is a great example of where the federal government has taken a small step in a direction that was always intended in our health system when it was first created. And we want to see it go further because we know that this should be part of that shift in investment that Dr. Kieran was talking about, where we want to see more investments in primary care, public health, mental health, keeping people healthy in the community so that we don't have to spend as much money on the expensive cancer treatments, on the hospital stays, the ICU admissions, all the things where we spend the majority of our healthcare dollars right now.
It sure would be nice to hear the federal leaders discuss some of these issues we've been talking about today. So, Dr. Reimer, what do you think about the fact that the debate organizers have chosen not to make health a theme in the leaders' debates this week?
I was deeply disappointed to see that health and healthcare were not included in the 5 themes for either the French or the English debates, because we know how important this is. Now, it makes perfect sense that we're talking about the economy in the debates and in the election overall, because we are seeing such a shifting landscape in the economy with our relationship with the US and tariffs. But the economy and health are so deeply interlinked that I don't think we can separate those. We know income is the #1 determinant of health, and we know that we need healthy Canadians to have a healthy economy. And so I want to hear, whether or not it's an official theme in the debates, I want to hear every leader talking about how they're going to improve health and healthcare in Canada, because it is essential for a strong economy that we have a strong health system. The health system is going to be part of what helps us mitigate the impacts of these tariffs. So it was deeply disappointing there, and it's been disappointing to not see it being front and center in each of the party platforms. There's been some conversation that we've talked about pharmacare with most of the parties, but to really talk about what they're planning to do on the healthcare system overall, not a lot of conversation. And we've seen in an Abacus poll, I think there was also potentially an Ipsos poll that showed that this is in the top 3 areas that Canadians want to hear about during this election. So it is clearly important to Canadians, and it's clearly important even if we're focusing on the economy.
Would anybody else like to weigh in on that? What do you think about the fact that the debates aren't going to touch on these subjects? Maybe you, Andre?
Yeah, again, as Dr. Reimer said, I think quite disappointing, a bit short-sighted. You can't have a healthy economy without healthy people. It's an issue where we spend a lot of money. The future of our nation is healthy children. There's a multitude of reasons why we should be talking about this, and it's unfortunate. I think the excuse always becomes, well, healthcare is a provincial responsibility, and I think that's a very misunderstood question. As Dr. Kieran alluded to earlier, the federal government is a big provider of healthcare. It's the 5th largest healthcare system, responsible for the growing Indigenous population, for prisoners, for refugees, immigrants, the RCMP, the armed forces. They have a big responsibility to deliver healthcare. So that's an important role. They have a funding role, $50 billion a year. As we've heard, it's not clear where that money goes exactly, but it's a big chunk. And I think ultimately the federal government has a role to create a semblance of a national system. We have the Constitution that we do, so it's decentralized, but there's no reason our systems can't cooperate. I always say that there's no constitutional impediment to cooperation, and that's a lot of these questions we've talked about today. That's all they require. Why don't we have better records? Because we don't cooperate. It's not a technical issue. Why don't we have one national license for doctors? Because we just don't sit down in a room and do it. It should take 5 minutes. These are the frustrations of having this as an excuse. Oh, well, it's constitutional. We always fall back on that, and it's not a good excuse.
Dr. Smith, what do you think about the? Yeah, I knew your hand was going to go up. What do you think about the debates not
I'm
covering
squirming
this
in my
subject?
seat for sure.
Yeah.
You know what? I think it's incredibly tragic that we're not actually having this debate. If you look coast to coast to coast in any media outlet every day, we see the challenges of healthcare, whether it's quality of work life, whether it's access, whether it's cost, you name it. Education and healthcare consume about 70% of most provinces' budgets. And that, of course, is all reflected not only in the provincial tax base, but in the transfer payments. So if this election is actually about competitiveness and about economic renewal and transformation, you can't have the outcome not include addressing healthcare issues. And you can't, if we're hoping for economic transformation and attracting new industry to Canada, one of the first things new industrial partners are interested in, tell me about access to healthcare for my employees. Tell me about access to healthcare for people I'm trying to attract to the country. So I think it's disappointing. That having been said, Kelly, I think shame on us as Canadians. We say it's important. We haven't demanded it. We haven't demanded that each of the parties put out a very clear platform around health expenditure, and no more up in the clouds, wouldn't it be nice if, but how much money? How will you increase the transfers, or will you? Are you willing to explore public-private partnerships or not? Is universality sacrosanct? So at the moment, I think we also have to push hard, and I'll take your broad shoulders and Andre's and say, probably the people who might have the most influence on this one is pushing through our media colleagues to actually demand the leaders before this election is finished, tell us what their commitment, real commitment to healthcare is. At the moment, it's platitudes and lovely discussion, but not many deliverables.
Dr. Kieran, is there anything you wanted to add on that?
I mean, I completely agree with my colleagues. We're at a critical juncture in healthcare, and we know that it's something that Canadians value dearly, and we also know at the same time that our healthcare system is struggling like it hasn't before. And so it's ever more important that we'll be talking about it. I think one thing that I worry about is that maybe one of the reasons that political parties didn't put forward more on healthcare is because they're not sure that this is a solvable issue. Maybe they feel themselves, that a little bit, can I actually do something to make any of these problems better? And I think that would be sad if that was the case that they're thinking, because I do think that there are actual real solutions. We heard from people in this panel today what some of the things what some of the federal parties and federal leaders could be doing. Everything as basic as transparency to new legislation. And so, I just echo what Dr. Smith says to end here, that we, people who are listening right now, it's, we want you to be able to raise this with your candidates. Tell them that this is an important issue, that, for you, whether you can have access to healthcare is something that matters, and ask them, press them on what their solutions is. Because I 100% agree that the only way this is going to be an election issue in this election or in elections moving forward is with public pressure, and that comes from all of us.
We've got about 5 minutes left, and so I'd like to use it to take a couple of last questions from our viewers and to say thanks to everybody who has submitted questions. This is one I want to direct to Andre, because it was the subject of an excellent book he published a couple of years ago. So, the growing seniors demographic presents the largest single challenge to Canada's healthcare delivery sector. What about long-term care? What about home care? How are our leaders going to address this?
Yeah, the silence there is deafening, unfortunately. And we know that seniors account for about 2/3 of all health spending. And that's not a critique. That's how insurance is supposed to work. You pay into it your whole life, and then you draw from it when you need it near the end of life. So they are a very important demographic, but the system is not built for them. I mentioned this earlier, but our system was built in the 1950s and 60s for a young population. Now we have for childbirth, etc. Now we have an aging population that needs multiple chronic care interventions all the time. So we have to rethink the system fairly fundamentally. Aging at home, aging in place has to be a priority. It's much more cost effective. It's what people want. So we have to adjust. We can't just be sending people off to homes off by the highway and they're forgotten. Again, there are lessons from other countries. The countries that have the best elder care have a philosophy that people should participate in society until the end. We often write about Denmark. Denmark has small long-term care homes. It has a lot really good home care. It's invested far less in hospitals and more in community care. These are political choices that we make, and when we make choices otherwise, we get different results. So yeah, I think it's unfortunate, especially this large voting bloc. Politicians know that seniors vote. I did an event like this last week, very similar to this, where with 2,000 seniors online, and that's all they wanted to talk about. What are the candidates promising us to make our healthcare better? And it wasn't all about we want more money. It's like we have insurance, we want to use it better, we want to have a better system, we want to stay at home as long as possible. People know what they want, and the system isn't answering their needs.
All right, I think we are officially coming close enough that if I tried to throw in one more question, we would go over time. So I think it's probably best that we wrap this up, although I could ask you all questions about this for easily another hour. So thank you very much, Dr. Reimer, Dr. Smith, Dr. Kieran, and Andre for joining us and for sharing your insights and advice. I also want to thank everybody who tuned in for this webcast today. We really appreciate your time and your interest in this important subject. I want to give you a final reminder that a recording of this webcast will be sent to everybody who registered. And you can also look for that edited transcript that I mentioned that will be in the paper soon. And lastly, if you enjoyed this Globe and Mail event, please check out our upcoming Intersect event. And to register for that, you can scan the QR code, which should be on your screen. If not now, then sometime in the next 30 seconds ago. The good people in tech behind me, I think, will throw that up shortly. And anyway, thanks again to all of you for your time and your smart thoughts and discussions today. And let's hope everybody, there's the slide for the Intersect event. That's going to be another great one that we'll be hosting here virtually at the Globe and Mail. So please do check that out. And in the meantime, everybody go out and nudge your politicians to help put healthcare onto the political agenda in time for the election on April 28th. Thank you all so much and have a fantastic afternoon.